needed for diarrhea. So how will you proceed? Aflatoxin is orfloxacin is ciprofloxacin with metrogyl or cefixime or azithromycin. So which one is the very good drug of choice? So whatever state guidelines says, ampicillin, Dr.A.V.M.Balaji, quinolones were very high resistant. So these drugs are not good drug of choice treating for gastrointestinal pathogen. So only third generation cephalosporin, that is cefixime or azithromycin, is the good drug of choice to treat acute gastroenteritis treatment. So move on to the next case. A varicose vein patient developed solely cellulitis followed by bullous formation. So we are dealing a case of necrotizing fasciitis. Necrotizing fasciitis. So antibiotic definitely needed. So necrotizing, if it is cellulitis, usually all the streptococcus species is the causative agent. If it is necrotizing fasciitis, your group B, so all the streptococcus sometimes all gram negative, even anaerobes also a pathogen. So mixed infection will cause necrotizing fasciitis. We need to cover all ages. For if it is cellulitis, only we have to cover the streptococcal coverage only. So either amoxicillin with azithromycin, verapinum, piptas with azithromycin, or piptas with clindamycin. So which could be the agent? Let us see. Our guideline says piperacillin tazobactam along with clindamycin. Alternatively, verapinum plus clindamycin. Why? Amoxicillin will cover step MSSA, sometimes with anaerobe, sometimes with the gram negative bacteria, but cover with MRSA only there. If you use azithromycin, no amount of coverage, very minimal coverage over MRSA and GMB, so good coverage over streptococcus as well as MSSA. So if you combine these two drugs, amoxicillin, azithromycin, all the agents won't be covered. But if you go with the piptas, verapinum or clindamycin, piptas, verapinum, no MRSA cover, but clindamycin, no GMB cover. So these two combinedly added, all the 5 agents will be equally covered. So piptas, clindamycin is the drug of choice to treat necrotizing fasciitis. Then move on to the next case. 78-year-old male, body maturation, fever 2 days, loin pain. So whenever there is a urinary symptom, body maturation and frequency of urine along with fever, we are dealing a case of complicated urinary tract infection. If no fever, that is uncomplicated urinary tract infection. So we are dealing a case of complicated urinary tract infection. There is renal under tenderness, BP also low. So we are dealing a case of acute, that is complicated urinary tract infection, acute pyelonephritis, and also patients slowly went for urosepsis. So what could be the agent? Nitrofurantoin, cefatoxin, piptas or ertapenem. So whatever state guideline says, you will see. So complicated UTI, if it is acute pyelonephritis, go with carbapenem only. Then imipenem, verapinum is the second line of drug of choice. You can check piperacillin tazobactam. If there is septic shock is there, along with the bacteria, is not a good drug of choice as per Merino trial. We have to know upper UTI, the nitrofurantoin, oral phosphonation should not be used. UTI, macrolide, tetracycline, polymyxin B, echinocandin, liposomal amphotericin B should not be used. So nitrofurantoin, no drug of choice. Cefatoxin, almost 80% were ESBL, no use. Piptas, patient already on sepsis, so not a good drug of choice. So ertapenem is the drug of choice to treat our patient. Move on to the next case. 30-year-old male, dog bite 3 days ago. Patient already on ARV. Come on day with infected wound. So what would be the drug of choice? So either amoxicillin, clindamycin, cephaloxin or azithromycin. So what would be the drug of choice? So what is the this is the commonest this is the ICMR guideline showing amoxicillin is the good drug of choice for all type of animal bite. So our state guidelines also saying both dog bite as well as human bite, amoxicillin is the drug of choice. So these are the commonest agent: Pasteurella, Malthusia, staph intermediates, dog bite, Capnocytomeca, both cat bite as well as dog bite, Legionella carolinens, most commonly from the human bite.